A couple of disclosures. I'm a consultant in Proctor, and I received research grants from Boston Scientific and Abbott Vascular for LAA closure devices. So when I was preparing this talk about limits with LAA closure, I thought about, well, number one, does LAA closure target, or, oh, there you are again. I'm kind of short, so the pleasure in standing up on a stool. So when I thought about, well, does LAA closure eliminate all sources of stroke related to atrial fibrillation? And number two, how does it compare to the gold standard, which is oral anticoagulation? What are the exclusion criteria, be it clinical exclusion or anatomical exclusion, and what are the complications related to LAAC? So number one, LAA closure unfortunately does not prevent non-LAA related thromboembolism. And we learned from autopsy and TEE studies that when thrombi occur in a setting of non-valvular AFib, in about 90% of cases, they do reside in the LAA, but there's still the remaining 10% that reside in the left atrium that LAA closure does not target. In addition, there can be other sources of stroke in patients with AFib, such as clot or atheroma from the ascending aorta or carotid disease, and those are not targeted, obviously. So what about comparison to the current gold standard, the first-line therapy, which is NOAC? Well, we do have data comparing Watchman to warfarin, as you know, from PROTECT and PREVAIL, and it does have pretty good comparative results in terms of being non-inferior and even superior, but where's the data comparing to NOAC? Well, there is none. There is a current ongoing study called the PROG-17 study, which is funded by the Czech government. It's currently ongoing as a multi-center prospective randomized trial comparing LAA closure with any device versus NOAC, and this is only a 400-patient study. I think they're just over halfway done. But if you look at the primary endpoint, this study is really a composite of both clinical endpoints and complications that includes stroke, systemic embolization, significant bleeding, cardiovascular death, and device-related complications. So I'm not sure what we can learn that much from this 400-patient study. There's another study called the A3-ICH study, which is planned in France. 300 patients will be randomized to apixaban LAA closure versus no anticoagulant for these patients with prior intracranial hemorrhage. And again, this is a small study, but I do think it's important to study this because currently patients with prior intracranial hemorrhage constitutes a pretty large proportion of patients being treated with LAA closure globally. What about exclusion for LAA closure? If we look at the current indications here in the US, Watchman is indicated for patients who are deemed suitable for warfarin and yet have an alternate rationale or reason to seek a non-pharmacologic therapy. But coverage is a different story. As you know, for CMS coverage, you need a CHASVAS score of 3, and you have to be suitable for short-term warfarin, but not able to take long-term or anticoagulation, sort of putting patients into the relative contraindication realm. And in the rest of the world, the guidelines from ESC would tell us this therapy has its Class 2B indication for patients considered contraindicated to oral anticoagulation. When you look at ACEP2 study, which is a randomized trial comparing patients who are contraindicated to OAC to LAA closure with Watchman versus aspirin alone. If you look at the clinical exclusion, I think we can learn from some of these exclusions. So these include history of percutaneous ASD or PFO closure, patients with mechanical valves, patients with severe heart failure, class 4, EF less than 30%, patients with poor life expectancy, less than 2 years, and patients with hypercoagulable state. So there are also echo exclusion criteria. Obviously, presence of LAA thrombus would be an exclusion, even intracardiac thrombus elsewhere, intracardiac tumor, patients with significant mitral valve stenosis, complex atheroma, we should consider as an exclusion. So in aggregate, I sort of grouped them together. What are the patients we should think about excluding for LAA closure? So those with mechanical valves, significant mitral stenosis, cardiac tumor, hypercoagulable state, poor life expectancy. I would say relative contraindication for previous percutaneous ASD PFO occluders, because you can puncture your transeptal above, below, or even through these devices. Intracardiac thrombus, I said relative because even patients with LAA thrombus, we have closed some of these patients when they don't have other alternative in terms of not being a candidate for LAA for oral anticoagulation. Even in terms of LAA anatomy, this is even a lower proportion of patients will be excluded because we have different devices that are available. So what about procedural complications? So LAA closure, I think, has really gone a long way in terms of periprocedural complications. So if you look at the initial experience, the first half of PROTECT, these 7-day events of perforation, tamponade, stroke, device embolization, and vascular complications was almost 10%. About half of those was due to tamponade. But in recent years, if you look at Evolution, which is a 1,000 patient real-world registry, primarily from Europe, this 7-day complication is down to 2.8%. And when you look at the more objective complication, serious complication of pericardial tamponade, stroke, device embolization that requires surgical excision, and procedure-related death, it's down to less than 1.5%, even in the post-approval US cohort, in the early experience here in the US as well. So we've really come a long way, but for preventative therapy like LAA closure, I think we can achieve even lower. What about with other devices? If you look at Amulet, which is the second device that's most widely used globally for LAA closure, in this registry of 1,000 patients, primarily in Europe, the 7-day major complication of stroke, systemic embolization, and cardiovascular death was also pretty low, 0.6%. When you add in bleeding complications like BARC 3 or greater bleed, device embolization, or vascular complication, it goes up to 3.6%. So relatively low, but I still think there is room for improvement. What about some of the longer-term potential complications with device-related thrombus and peri-device leak? Well, with peri-device leak, we know that with Watchman is not infrequent. In fact, about 30% of these devices would have some degree of leak at later follow-up. But significant severe leak, more than 5 millimeters, is actually pretty infrequent. That's less than 1%. And fortunately, in post-hoc analysis, we have not seen interaction between the presence of residual flow versus clinical outcome. Likewise, with the ACP device and Amulet device, peri-device leak, yes, occurs maybe about 12%, perhaps a bit less compared to Watchman. Severe leak, more than 5 millimeters, really is non-existent with Amulet. Between 3 to 5 millimeter leak, about 1% with the Amulet. We've also shown that the presence of leak did not correlate to thromboembolic events as well, which is reassuring. So the guidelines in terms of when to survey for these peri-device leak would be typically doing device surveillance imaging around 6 to 12 weeks with either TEE or CT. And management really depends on how big the leak is. If you have a leak that's greater than 5 millimeters, probably most will agree that you should continue on anticoagulation long-term or perhaps consider a second closure device. Now, what about device-related thrombus? And I'll finish here. I think this really is the major Achilles heel of this device therapy, is thrombus on these devices. And if you look at, the conglomerate of data, I pulled them into this table. You can see we have a lot of studies now that looked at the incidence of device-related thrombus. With any of these devices out there, it's really somewhere in the range of 3 to 4%. And these are not benign. The associated strokes with these thrombus on device ranges from 7% to 26%. So when you see these clots on the device, they have to be treated. I really like this study that was published recently this year from France, from 8 centers in France. They included 470 patients. The overall device-related thrombus rate was 5.4% in that study. And when you look at the risk of stroke, when you have thrombus on the device, the hazard ratio was 4.7. So it's not benign. And when you look at the hazard ratio of getting thrombus on the device, if you are on DEP therapy, your hazard ratio is 0.1. If you are on OAC at discharge, your hazard ratio is 0.25. And in this study in France, the practice is very different because, outside of the US, a lot of patients getting LAA closure are contraindicated. So if you look at what antithrombotic treatment therapy they received, 8% had no antithrombotic therapy, 36% were treated with aspirin alone, and the remainder, about half, were treated with DEP therapy, and about half received OAC. But this study just highlights that, if you're not treating a patient with DAP or OAC post-LAA closure, you're probably not doing the best thing for this patient in terms of preventing device-associated thrombus. So there's no consensus on when to screen for device-related thrombus, but most of us would do at least one imaging, some would do 2. So the first between 6 to 12 weeks and probably a second one at 12 months. If you see clot, you really should intensify your oral anticoagulation or add an anticoagulation. In rare cases, in less than 5% of cases, you'll require surgical excision. So in summary, NOAC remains the first-line therapy for stroke prevention for patients with non-valvular AFib. We do need comparative data for LA closure versus NOAC. LA closure is not suited for all patients. Remember, it does not treat all non-LAA related stroke. There are clinical and anatomical exclusion. We need to continue to strive to lower the complication rates for this procedure, and we need further refinements in device designs and implant techniques and antithrombotic therapy to really lower the incidence of leaks and thrombus. Thank you.
Jackie, I have a quick question. I know you have to leave about ASAP2 patient enrollment. Theoretically, ASAP2 and commercial indication of Watchman should not overlap. But there is a gray zone in the clinical practice where a patient may not be an ideal candidate, but centers may choose to do a commercial Watchman with DAPT as an off-label. How do you consent a patient, or how do you screen the patient in clinic when you're seeing for the first time and you're trying to get him or her in an ASAP2, whereas a neighboring hospital may be sending flyers for like an off-label commercial?
Right. I think the mindset has changed a little bit. I think the ASAP2 is an incredibly important study, and the FDA really pushed for that, because that really will help us expand our indication for this procedure, hopefully to class 2A even, in the national guidelines. So we really should strive to enroll patients. Right now we're only about 20% complete in terms of enrollment of 888 patients. And I think if you see a patient who meets the criteria for a contraindication, the first line would be, if you're a center with ASAP2, I think we should approach the patient for that first. I think off-label use, obviously we can't stop off-label use, unfortunately. And in a center that is not involved in ASAP2, I guess you don't really have an option for these patients, and so the option in these patients would be, what do you do? Would you send them to Lariat, or or you just leave them the aspirin, for instance, for stroke prevention? May not be the optimal thing. So I think you got to individualize it, and you got to depend on the centers whether you have access to that. I know in Canada, because all patients I'm considering for ASAP2, I have been implanting Watchmans in the past. So it's actually quite challenging to enroll our patients, because my referring doctors have been sending me to do the procedure. Now I tell them, well, you have a 2-to-1 chance to get this. Right. I mean, not every patient is suitable for ASAP2, right? It's because some of them, they may not meet all the anatomical criteria that we have, and some patients are just, they just don't want to be involved with very rigorous clinical follow-up. So you can right off the bat exclude them, and then I can do them sort of outside of ASAP2. But it's a challenging thing. I think globally we're having issues and challenges in enrolling patients, not just in the US, but elsewhere, in Germany too. So